Well, I'm very pleased to welcome you back to the next part of our IOM committee's work on end of life. I think that you would all agree with me that this morning's both presentation and panel really grounded the discussion that we've had in a very human and real sense, and I'm very grateful for everyone for those contributions. We spoke yesterday about the reality that our discussions are not really about hospital-based issues without taking into account the impact that the end-of-life issues have on families and on communities, and I think this has been a great launching point for that dialogue. I want to remind everybody that we're being webcasted, and there's also a Twitter feed on Hatch End of Life. And if you wish to do that, please do. And I'm very, very pleased that we'll now move on to our next panel. And I'm very pleased to introduce one of our colleagues, Dr. Vijay Perikal, who directs palliative care education at Stanford and has done a wonderful job for us. And we're very pleased to have her introduce the topic and to today's panel. This is going to be a focus on communities and culture, thinking about how they are affected and what we can learn and how we can better communicate with our communities in a more successful manner. So Vijay, please.
Thank you so much for having me here and giving me this wonderful opportunity to talk about something that is so close to my heart. It's such a pleasure to see so many wonderful members of the public here, and so I hope that there will be some time later this day for you guys to ask some questions. So we are shifting gears. So far we talked about family caregivers, and in my talk, my goal is to think more about how we can do whatever it is that we want to do ultimately based on this committee's decision to make it inclusive, so that it is something that all the ethnic groups, all the cultures, and earlier we were actually talking about pediatrics in and of itself having a culture, biomedicine in and of itself having a culture. So I want you to think about culture a bit more broadly. And so in terms of my talk, what I'm going to do is first give you a little bit of an overview, and then I'm going to show you 2 videos so that you can get a little bit of an immersion experience in terms of what it is that we are describing. And then from there, we'll go to the panelists who are here to tell us a little bit about what it is that they have done that is working really well. What are some of the lessons that they've learned that they can share with us? So to go back to this main message from today, when we think about palliative care, I feel like we do a pretty good job thinking about the biopsycho, social, spiritual aspects of care, and I think that has somehow become part of the genome of palliative care. What I think is still sort of a software fix here, you're in the Silicon Valley, so you have to get used to all the software metaphors here. So what is a little bit of still a fix or a patch is the cultural aspect. So it's not that anyone thinks it is unimportant. We know that it's intrinsically the fabric of the people that we work with and how we think and make decisions, but I think it is still not hardwired into the whole thinking process. So hold that thought for a minute, and so far we've talked a little bit about pediatrics, and we'll be coming back to pediatrics again when our colleagues from George Marks are going to give some information. But now I want you to pull to the other end of the life cycle, where we are going to talk a little bit about how the US is an aging nation. So I think we know this already. People even talk about the fact that the Silver Tsunami is here. So I think I see a lot of heads nodding. So that's something that people are familiar with. What people are less familiar with is it's not just a silver tsunami, it's also a silver brown tsunami. The number of ethnic population is actually on the increase, and I'm going to show you some numbers. So the efforts that we've been doing, and I'm putting this in context for you now, is we are focusing on these 13 different ethnic groups here. So right now what I'm going to do is show you one video immersion clip that you can watch, and the topic is going to be end-of-life conversations, and the overall question I want you to reflect on as you watch this interaction is what parts of it felt easy, and some parts of it probably are not so easy, and the question I'm posing to you is, why is this so hard? I'm going to show you some data and I think a lot of the people here who have generated the data are here, who have talked about how challenging it is to be able to facilitate good access to early palliative care for ethnic minorities. There's tremendous amount of data, and I'm going to touch on it a little bit later. But before we even go there, I want to bring you into the clinic room of a patient. So the patient in this case, it's a triad, a father, mom, and an adult daughter, and they're going to be in the office with an oncologist who many of you will recognize. And it's a generic cancer. Think about it as, in this case, it's colon cancer, but basically it's a cancer diagnosis. Similar scenario can play out in a non-cancer diagnosis as well. So let's watch that clip first.
The x-rays do show the cancer is worse. It's getting bigger despite everything we're doing.
You absolutely sure about that, doctor?
I'm as sure as I can be, yes. I checked it myself with the radiologist. We've treated this as aggressively as I know how. One of the sad things is we don't have the cure for colon cancer like you have. I wish we did.
So what's now? What do we need to know? What do we need to do?
Well, I think there are a couple of next steps. The first is I think we should stop this chemotherapy because it's not working. And I'm hoping that you'll start feeling a little better when we do that. I can review with my colleagues. I can call around the country to see if there's anything experimental that might be helpful in your situation.
Oh, God, no.
I want you to know that I will do everything in my power to have you feel as good as possible. We're not going to give up on you. We're going to keep trying to take the best care of you we know how.
We're all in shock right now, but
Of course you are.
I appreciate you, sitting down, talking with us. But it's just a lot for us to take in right now.
Right.
It's a lot.
And any resources you can provide us with, we'd be really appreciative.
I will do that. Do you have any other experiences of people with cancer in your family or people you've known?
Yes, my sister died of breast cancer.
And Uncle Kenny,
Mm-hmm.
he had cancer.
It would help me to know what those experiences were like. Because sometimes it causes people to be very afraid when they've seen other things or people in the family, particularly if things haven't gone well. Would you be willing to share that with me?
Well, they didn't go to the doctor.
Right.
They kind of
Right.
neglected their health until it was
Too late. I mean, we came in early thinking that we could get out ahead of this, so this is kind of devastating to us right now.
Right. So you
But
felt like thought you were doing something different,
Right,
and you were hoping then
yeah.
the outcome would be different. Yeah, I can see that. For your family members, did they suffer a lot? The ones that had the cancer?
Uncle Kenny did.
We took him home, and he suffered right through hospice, and he wanted to be home.
He wanted to be home with us. We brought him right to our house.
I mean, that's what I want too.
So you had the hospice team come in, and she was in your home?
Yes.
Oh,
Yes.
what was that like for you?
It was
Tough.
It was hard.
Yeah.
Because I stayed at home and did most of it when the hospice came in. But it was nice having him there because we didn't have to go back and forth to the hospital.
Uh-huh.
He was around family.
You're not suggesting hospice for me, right?
I'm not suggesting that now. I want to explore, based on my experience of other people, the things that make them worry. We're doing everything we humanly know how to do.
We're going to keep fighting.
And we can keep on fighting.
Absolutely.
Absolutely.
We're going to keep fighting, Daddy.
Yeah.
We're going to keep fighting. Okay?
I'm gonna leave it to you guys to
We're
take
gonna-
this to the
We're going
next
to leave it
step.
with God. We're going to pray.
So I hear that you rely a lot on your wife and your daughter here.
Yes.
And I'm hearing that this is a family affair. All of you want to be a part of this.
Oh, yeah.
And I'm hearing that with these two family members, that when that time came, you had them at home and you did as good as you could, until the day they died, and you kept praying until the day they died. Is that right?
Praying for a miracle.
And I think that's terrific.
Don't give up on me, Doctor.
I won't give up on
This
you,
is not something that
not for a day.
I'm ready to give up on. I'm
No.
going to fight this.
Right, so let's fight it. I'm going to make a note in the medical record about this conversation. Before you leave today, I will give you the name of a couple of colleagues that could provide second opinion.
So are you out of the picture now?
I'm not out of the picture. I'm your doctor as long as you want me.
Good.
All I want to do is make sure that you feel like you can trust the medical advice you're given.
What else can I do? We go to the next step and see
Right.
if there's still hope.
Okay. So I'm hearing we need to take this step by step. I'm hearing you're leaning hard on your wife and your daughter here to help you through this. I want you to lean on me too. We're going to take it step by step.
Thank you. We appreciate that.
Okay.
Thank you so much.
You are lucky to have the family you have.
Thank you.
Okay.
That's all
We're
I have.
lucky to
Is my
have
family.
him.
Yeah. Yeah. All right. So I'm going to do those things, and I'll make sure that you get that before you leave the office today.
Thank you so
Okay,
much.
thank you.
Okay.
We're gonna make it. We're gonna make it. It's gonna be.
I sure
okay.
didn't expect this. I was just
gonna get
expecting
another
better
opinion.
news. And
He said that he's gonna get us in contact with some of his
Some other
colleagues.
people, we're
how am
gonna,
I supposed to plan for this?
we're gonna take it day by day, Daddy. We're gonna read, we're gonna see the people that he wants us to see. We're gonna, we're gonna ask the questions. We're gonna get through this, okay?
And where's your faith? Where's your faith?
Yeah.
Where's your faith?
Yeah. Just tell me
Where's
what
your
to expect.
faith?
I just
We're
want
gonna
to.
get through it. He's gonna give us some resources. We're gonna get
I know
through it,
you
okay?
guys are going to support me through
No,
this.
of course, Daddy.
I think I've been in thousands of conversations like this, and it's just as hard every single time you do this. And I always tell myself that when it ceases to be as hard, that's when I should be thinking about retiring. Because anytime you think that end-of-life conversation is easy, then we are not in the right business. It might be, I've done it thousands of times, but it's the very first time for that particular family. And so the gravity is always extraordinarily higher than I can ever estimate it to be. The reason we actually, so these were not card-carrying actors. These were regular people in the community who wanted to be activated and participate. The physician is a very respected colleague, Dr. Charles Von Gunton, and even when we were doing this, we did this with various different ethnic groups. Same scenario to see how the individual culture would determine the way the conversation went. None of it was scripted. And we intentionally let the camera on after the physician stepped out. And I don't know if you noticed that collective sigh, how they were keeping it together for the doctor. And after the doctor left, they were themselves. They're not supposed to be keeping it together for us. We are supposed to be keeping it together for them. And so that's the leap that I think we need to make so that we can do that for all of these families, all these ethnic groups. So I told you earlier that the Silver Tsunami is here, and so now I'm going to give you a little bit of data, and then we'll come back to another video. We'll finish with that. So 4 out of 5 hospice recipients currently are older adults. Okay, and as in my business, which is geriatrics, we talk about geriatrics, which is the old, and I always think that the more geriatrics we have, the more older adults we have, it is actually a living testimony to how modern biomedicine is helping people. But then comes the next question, are we increasing just quantity of life at the cost of quality? And is there something that we need to do to bring the patient and the family into the loop early in the day, as our panelists were saying, right from day number 1, so that they can do the shared decision making and we are not imposing our values on them. Having said that, one of the big challenges that we have is end of life is still a retrospective diagnosis, meaning someone dies today, and so I know the last 6 months what I was doing was actually end of life care, except that I went around it in a very meandering fashion through the ICU, through the BMT, through the ER multiple times, and then finally into end of life. So we need to have better systems in place, not to prognosticate as much as to have concurrent care from day number 1. So I'm giving you data here, we do too little, too late. So just in case, I already told you that prognostication collectively as a nation is not that great. So in 2009, the average length of stay in home hospice was 21.1 days, which means collectively we knew 3 weeks before they were dying that they were going to die, right? That's a simplistic way of thinking about it. And so if you thought that was not good, think about how we did in 2010. So we're going in the wrong direction. Racial disparities really shouldn't persist until the end of life. And there is, I think AHRQ recently released this big health disparity issues, and so we are very bipartisan in that. We don't spare any age in terms of disparity, so racial disparities continue until the end of life. Having said that, one thought that might be going through your head is, this affects only a small portion of the population. Why is she here talking about this? Well, 30 years from now, this is 2013, 30 years from now, the US is going to become a majority-minority nation, or you can call it a minority-majority nation. So I've given you the population here, and now I'm going to give you how we are going to change. So right now we are at 37%. In 2060, this is the projected population, we are going up to 57%. And I also want to point out, look at how the gerogeriatric population, which is 85 and older, 18.2 million. We can barely take care of them right now in our ability to provide home care services, home health aid, caregiver support. Well, they are going to almost quadruple. And you might think, it's just 40 years is a long time. 40 years is a long time for an individual, not for a nation. So I've given you more data here about hospice patients by the race. So here we have 77% of the hospice consumption. Think of it as an entitlement, because if I'm dying, I want to be in hospice care, and so I'm entitled to it. So in that sense, 77% is being consumed by the Caucasian population. Not that anyone is stopping the other ethnic minorities from consuming hospice care. We just need to message it in a way that it is acceptable and culturally effective. So here I've given you 2010 hospice patients by ethnicity. And so here you can see that 16.7% of the nation's Latino population only account for 5.7% of hospice care. Lots of data here, and I've given you all the various studies here. This is just a summary slide that culturally diverse groups are less likely to consider themselves terminally ill, more likely to want to get intensive care, less likely to want to do advanced care planning, less likely to enroll in hospice, more likely to revoke hospice, and if you ask decedents, and some of the PIs of all these projects are actually right here, the families are less satisfied with hospice care. So again, when you think about it as a healthcare, we call ourselves a service, right? So we are healthcare service, but think about it for a minute like we are an industry, like we are Apple. If our consumer doesn't like what we do, Apple doesn't walk away. So we say what we need to do is think about how can we repackage, reorient, redetermine what it is that we offer so that it's acceptable to everyone. So if they don't accept it, it's on us. It behooves us to change our practice. Culture really shouldn't influence how we deal with serious illness, and so I'm going to give you two-part data, and then we'll finish up with a video. So thinking about culture, we always think about those others who are sitting in that other room and making unusual decisions. I'm going to first show you doctors' perceptions of barriers to good end-of-life conversations. So this is an N of 1037 doctors here locally. I've given you the gender distribution, almost half and half, and all subspecialties, primary care, super specialized, the whole kit and caboodle. Ethnic background of the doctors. Okay, so it's very reflective of the Bay Area population. And so here you have, again, almost 50-50, right? So 49% Caucasian, and then we have all these other ethnic groups. So barriers to good end-of-life conversations with diverse populations. So the question asked to the doctors was, what is preventing you from having good end-of-life conversations with ethnic patients who are seriously ill? So any guesses on what the survey says? Time, okay. Any more? Language. What else? Prior bad experience. So working with medical interpreters was thought to be a rate-limiting step in having good end-of-life conversations, which is completely counterintuitive because the class national standards tell you that you need to have access to medical interpreters. So this obviously is a real concern, and not sure that we can do anything too fast about it. Ethnic patients having limited health literacy. Ethnic persons have decreased level of comfort in openly discussing death, dying, and end-of-life care. So that, to me, is a cultural value. And so if we are waiting for that to change, I think we are going to wait for a long time. So we need to figure out, given all these constraints, what can we do? How can we alter our practice in a way to make care available? This was great. At least it made the fifth most important or the fifth most common thing in the rank ordering, that there was some self-reflection and self-awareness that maybe just a little bit we could be a little bit better. Differing religious beliefs about death and afterlife. Again, cannot change that. People are not going to change their religion for their doctor. They'll do a lot of things, but they won't change their religion. So that's another thing that we have to learn to work with. And then trust. This came in as the last issue that our physicians felt. So I've given you the reasons why this information is important, the changing demographic terrain. You saw a case of a patient and family having a real life, flesh and blood discussion, as you saw, and the distress in that. You heard about what the doctors think about what the barriers are to end-of-life care. So now I'm going to show you what do the patients think. And as I was telling you, we work with 13 different ethnic groups, so I have 3 of the groups here as a sample for you to watch.
As a culture of people, we don't really trust the doctors because we just haven't had good success with our families surviving. So I just really want the doctor to let us, keep us abreast of what's going on every step of the way, because right now I just really don't know.
The Latino family embraces the family as a whole, so it's not affected just with the 5 children that are in that family. It's all the relatives that belong to that family. It's very important that we're understood by the doctor, and that we understand correctly what the doctor is actually saying to us.
I need the medical community and the doctors and the staff to understand where my parents are coming from culturally and historically. I need them to understand that my parents are from a time when people in their community died having to seek out medical care because there were many hospitals that they couldn't go to. And in the process of getting to a hospital that allowed them to come, I've heard the stories of family members and people in the community that have died trying to get to medical care.
They still have a lot of the culture from the old world. I think their value would be like a traditional Chinese value, which is different from an ABC. ABC is American-born Chinese. American-born Chinese is just like an American. Where they're thinking, how they their lifestyle will be completely American. My understanding is that for someone who just came from another country, the main concern is translation. Whether they can have a translator standing right beside them to interpret what the doctor wants to tell them and what they want to tell the doctor.
To me, it's a very, very touchy subject, and I can't deal with that. So I leave it to my children and to those professionals that make decisions when we have any kind of an illness like cancer. And it's a horrible thing to hear a doctor tell you that you have cancer. And this is the first time in my family that I have to deal with, and that's why it's very difficult for me.
I think be a patient to you, and be generous, and to be understanding.
I don't trust doctors, basically. I When I come to a doctor, it's usually when I'm ready to go to the hospital, basically when I have no choice. And it's just going to be a situation where I'm not going to trust you until you show me that you're genuine about my concerns, that you tell me the truth, because that's really what I want, the truth.
So my family is actually from Hong Kong. They still live there right now. And from my own experiences, there's actually a lot of diversity, a lot of variation in what people want. My own grandfather insisted that he had to know everything. He refused to stop treatment because he needed to do something about his illness, even though the doctor said that the treatment was not really worth it. And, there's also other people, like a distant grandmother who my family strongly believes that she's doing better off, she's happier, she's healthier because she has no idea that she has leukemia. What I think is important to know is you can't really assume a family is a particular way. There's a lot of variation within each individual within the family, and sometimes even if you ask them ahead of time, what if? When the time comes, they'll probably change their mind.
When that moment comes, I can't say to give up. I can't do that. So you just pray that even if you don't give up, that God will decide ultimately anyway. But I can't make that decision.
So I'll leave you with that thought of why is this so difficult to have good end-of-life conversations? And so far, I feel like I've been giving bad news without the warning shot. I see some of my teachers here who are thinking, why didn't you use the spikes protocol to give bad news? So having said that, for the rest of this session, we are going to have experts from the community who have demonstrated with data, with their behaviors, how they have been able to access these diverse community and be able to provide quality palliative care and end-of-life services. So in terms of diversity, we have the entire life spectrum covered here, starting from the pediatrics with George Marks Children's House all the way to the geriatric end. So with that, I'm going to welcome our community expert panelists to please come and join us. So we have 3 community partners here. We have 2 representatives from the Alameda County Health Services Agency, Alex Briscoe, who is the director of the Health Services, Marilyn Ababio, who is their hospice systems coordinator. From the Chinese American Coalition of Compassionate Care, we have Sandy Stokes, who's the founder, and Jean E., who's the chair of the board. And then from representing George Marks Children's House, we have Barbara Beach, who is a co-founder and the medical director. So the question I wanted to pose to each of the committee members, so what I thought we would do is post the question on the wall, which I'll read to you, and then have each of you answer that question. So this first one is, what if each of you can tell us what is your mission of your organization, and given that, who do you serve? What cultures, what numbers, and how have you managed to carve out your sweet spot in promoting access to good health care? So Alex, I wonder if you can start.
So I feel a little bit like the fraud here because I'm actually representing the bureaucrat. And I'm the agency director for the Alameda County Healthcare Services Agency. So I'm the public health authority in Alameda County. And as the director of the agency, I oversee the departments of public health, behavioral health, including alcohol and drug and environmental health, including our indigent care and EMS system. So our mission is to provide fully integrated care in one of the most diverse counties in the nation. So we are a minority majority already. By ethnic plurality, we're one of the most diverse. We're sort of number 2 to Manhattan, frankly, but we're right up there. And we have frankly, taken a very aggressive and specific approach to addressing the social determinants of health. And in our approach, we've really taken a new look at what the role of the public sector is in the design and delivery of integrated and culturally relevant health services. And it's important to note that our health authority is quite different than any other. We are not a provider. While we have a public hospital and we're building a $700 million hospital and we do lots of stuff, about 80% of our $1 billion that we spend is delivered through a third-party intermediary, through a community-based organization. And we do that for two primary reasons. The first is it's cheaper. It's about 27% cheaper to pay a community-based organization than it is a civil servant, so we get more bang for our buck. The second is, as a extremely diverse community, we can't purchase the cultural relevance and cultural competence in the public sector. It simply can't be done. So we have the largest indigent care program per capita. We're one of only 3 counties left that provides healthcare regardless of immigration status. And when you come into our program, you don't actually walk into a public health clinic. You walk into La Clínica de la Raza, Asian Health Services, Tiburcio Vasquez, Lifelong. We contract out our Section 17,000 obligation for indigent care to community-based, federally qualified health centers. And we do it to an extent that no other health authority does. So to understand our approach to the challenge of diversity and racial and social equity, we've used a new vision of the public sector. The public sector as thought leader, as innovator, as funder, but not as provider. So that is really relatively distinct and unique. We've also taken a very strong epidemiological approach to population health and the social determinants of health. And as just a quick example of that, in 1960, African Americans in Alameda County lived 4 years less than their white counterparts. Today, African American Alameda County residents live 8 years shorter than their white counterparts. And frankly, the single largest challenge we face as a healthcare system is the impact of multi-generational poverty, particularly multi-generational poverty in poor communities of color. So we have, frankly, found that we can't treat away these disparities, but it takes a creative approach to culturally relevant care, and that means money. Things can't happen without resources. So one of the things Alameda County did is passed a half-cent sales tax for healthcare that produces over $100 million a year, and we've used it to invest in creative and innovative approaches to bring in culturally relevant care to communities living in multi-generational poverty. And we've been particularly interested in services that provide integrated care that flip the power dynamic between consumer and clinician. So using the triple aim approach, we looked at re-engineering our healthcare system. We built 28 federally qualified clinics in schools. We started clinics in fire stations and community colleges and day labor centers. But our model it was quickly apparent that our model was not taking into account the brown tsunami. And we frankly felt that we dramatically missed something. And by 2025, there will be a 150% increase in people living over the age of 65 in Alameda County. Our system is not prepared for that approach. So we took what we think is our role again, a new role for the public sector, took some scarce discretionary resources and invested in a hospice initiative, an end-of-life care initiative called Getting the Most Out of Life. And we invested Measure A dollars, this half-cent sales tax, to bring in an expert in culturally relevant care, and you're going to hear from her in a second, to lead initiative organizing the existing resources, mining the skill and wisdom and intelligence of those who are already providing this type of work, to develop an investment strategy for us moving forward. I guess I should finally end with, we set 4 specific objectives for ourselves. We looked at the utilization of hospice across ethnic groups, and we set a very specific and direct objective of expanding that in a defined time period. Our focus was increasing hospice utilization in underrepresented communities. We wanted to improve the public perception of hospice in poor communities of color. We wanted to outreach and partner with multilingual, multi-ethnic, faith, and community-based stakeholders. So we weren't bringing a new program to a community. We wanted to mine the existing places that Alliance already rests for the communities we're trying to serve. And we wanted to develop a sustainable palliative care practice, leveraging our expertise in Medicaid.
So, thank you so much, Alex. Can I invite the Chinese American Coalition of Compassionate Care to answer the same question?
Hi, my name is Sandy Chan Stokes. I'm the founder of Chinese American Coalition for Compassionate Care. I'm going to say CACCC, otherwise my 5 minutes will be end very fast. CACCC was founded back in December 2005. And with all the things that VJ and everybody was talking about, the challenge that minority group were facing in end of life. In Chinese particularly, the reason we saw that from 1 to 7, actually from 7, 6, 5, 4, this is the one it's really critical we're facing every day. After we found this coalition, we thought it's going to be a big challenge for Chinese community because nobody wants to talk about death. We even cannot talk about cancer. Nobody talk about that. And that was only back 10 years ago. And I have to say, I'm so pleased to see a lot of my old friends from New York back east who we worked together 10 years ago, and we're still here. So I'm very happy to see that because what happened is after we formed this CACCC, we now grew out to a still very small organization, but we have about 80 partners, including Stanford and lots of local hospital, UCLA, UCSF, and also Laguna Honda Hospital, and many of the hospice agency. Then we starting working with Los Angeles area, Southern California. Then actually tonight we're going down to up to New York and starting our 30 hours Chinese volunteer in end-of-life care training. We have a group of Chinese who want to learn how to better care for the Chinese community facing end-of-life. Now, our job is how to be a bridge to help our Chinese community who have a bilingual, bicultural understanding, work with health providers to better serve them. So that coming to our purpose, why we have this coalition. We have several goals we want to achieve, which we already doing for the past 8 years. Number one, we like to educate ourselves. We were talking about the language and culture. It's not just language, but we start with all the translation. We translate a lot of the related information, and we develop a lot of a curriculum, all in Chinese and English. So people like ABC, somebody was just mentioning, that we have 3 generations here. We all work together with this end-of-life care. We want every generation knowing what the patient are thinking about. So all the material we prepare take us ongoing, but at least the very first couple years. So we have a lot of wonderful information there for either Chinese or non-Chinese care provider to use because it's bilingual. It's both English and Chinese. This way it's a feeding tube, okay? And we also developed the DVD with a lot of the education material there. Actually, that one is made, actually was invited by the Medicare through the Hospice Foundation of America. So we do this education material, and later on, we say we need to do the community outreach because we do not want to educate our Chinese population after the crisis start. It's a little bit too late, way too late. So we want to do a lot of education, including suicide prevention. All the information we train our speaker bureau came from some of them are health providers, some of them layperson, housewife, engineering, lawyer. They all have well-trained, bilingual, go to the community, provide services. So we are very active coalition. Right now we have about 1,400 individuals are our member nationwide, actually a lot international as well. And then why the health provider wanted to work with us. It took us 80 years to build our reputation by the best services we can provide. We work with them as become their partner or they become our partner. We go out to recruit the potential volunteers, bilingual, can be Mandarin, Cantonese, Thai sign, Shanghainese. And once they came into our training program, they have to receive a very complete 30 hours basic hospice and palliative care training, both in English and Chinese. and we have a simultaneous interpreter on site to do the interpretation services. So everybody's bilingual. After they complete the training, then they will have a choice to apply their local hospital, become palliative care volunteers, or the hospice volunteers. They are not CACCC's volunteers, but they are the individual or partner agency. So it's like a win-win situation. And later on, Jean will share some story. You will know why we're doing what we're doing.
Thank you, Sandy. Thank you so much. Barbara, I wonder if you can tell us from your perspective. Same question. What is your mission, and given that, who do you serve, numbers, and what is your sweet spot?
Okay. George Mark Children's House was opened in 2004 as the first freestanding pediatric palliative care house in the United States. And we modeled ourselves after those in the United Kingdom and Canada. And I believe at this moment there are about 49 of these children's houses. They call them children's hospices, but I don't like to use that word in pediatrics. So we call it a children's house, but it's basically a palliative care center. The population we serve is children with complex, chronic, progressive medical conditions and their families. And we anticipate that most of the children that we serve will die prior to full adulthood. Our mission is to provide the highest quality of care and the best quality of life possible from the moment of diagnosis on. So this can be years, it can be decades, through strong collaboration between families, the child's medical home, and our interdisciplinary team. So I want to make it really clear, we do not become that child's medical home. Our services are available to all medically eligible families, regardless of socioeconomic status or the ability to pay. And we never bill a family. A family never gets a bill from us. George Mark Children's House attempts to provide the medical necessities and benefits of the hospital, but in a comfortable, nurturing, home-like setting. It's like having your own private palliative care nurse in your own home. George Mark Children's House was designed as a 15,000 square foot home. It contains 8 private children's bedrooms, each with their own private bath. Oxygen, suction, and medical air are built into the wall, but are hidden from view behind a panel when not in use. And most of our children have some respiratory component to their illness. So whenever they need a treatment or if they need oxygen, we simply slide back the panel and we're able to provide that, so we don't have a lot of equipment around the beds at all. Family accommodations include a built-in window bed in each child's room, and there are 2 on-site one-bedroom apartments for the extended family to stay in. Because we operate as a palliative care center, we're not constrained by the usual hospice restrictions. We have no 6-month prognosis required. Prognostication can be very uncertain and inaccurate in our pediatric population, and many of our children continue to receive services for 5 years or longer with us. More than half of the children and the families we serve first come to George Mark not for end-of-life care, but for respite care. It's a huge need in our population, in our children's families. In addition to respite and end-of-life care, George Mark offers transitional care, which we see as a bridge between hospital and home, where a course of treatment can be completed, for example, a prolonged course of IV antibiotic therapy, weaning from respiratory support. So we're actually able to shorten the hospital stay of some of these children who spend all too much time in the hospital during their shortened lifespans. And also during transitional care, we can educate the child's family caregivers in the use of the same medical equipment that they will be using when their child returns home. So the DME company in the community actually delivers those pieces of equipment to George Mark, and the families can then use them 24/7 under the guidance and observation of our nurses. In addition, in contrast to the adult hospital model, we offer ongoing bereavement support following the death of a child, and the bereavement support is never time limited. So we always tell families, as long as we're in existence, we will be here to provide whatever bereavement support you need. Our experience at George Mark has been that many parents are unable to begin to actively seek or accept professional support for months or years following their loss. So that traditional 12-month hospice period really doesn't fit for a lot of parents. We're also very much aware that as bereaved siblings proceed through subsequent developmental stages after the loss of their brother or sister, their need for and acceptance of bereavement services changes over time. In our most recent fiscal year, we served 107 children with life-limiting illness and 250 of their family members. We had 147 admissions, 40 of which were readmissions. Our length of stay ranged from 1 day to 4 months, with an average of 12 days. We don't put a limit on the time period for an end-of-life length of stay. 84% of the families we served resided in the San Francisco Bay Area, including 58% from Alameda and Contra Costa counties. 14% came from elsewhere in California, 2% came from out of state. And based on self-identification, 38% were Caucasian, 19% Latino, 16% African American, 13% Asian, 4% identified as multi-ethnic, and 10% as other.
Thank you. So now that we've established your mission, the next data show, and I think I've talked a little bit about this earlier, data show that providing easy access, early access to quality palliative care for diverse population, it's not exactly low-hanging fruit. We know that. Having said that, you guys are here as positive deviants, if you will, and you've been able to demonstrate in your behavior, in your practice, that this can be done. What specific lessons have you learned that you can recommend for or against? And if you can use a patient story to illustrate your point, that would be really incredibly helpful. So I'm inviting Alameda County, Maryland, if you want to.
Okay, I'll begin. I'd like to begin by thanking the IOM and Dr. Perry Coyle for inviting me to be on the panel, and thanking Alex Briscoe for his vision. If we're successful in Alameda County, it's because we have a plan to increase hospice utilization and to institutionalize advanced care planning for people who cost the system a lot of money. It costs the system a lot of money because they wait to receive health care via an ambulance and the emergency room. But much, much more important is the fact that these are the very same people that bear the societal burdens of living in communities that are degraded by air, that do not have the resources that many of us have. A good death has a different meaning to different people. And our project, Getting the Most Out of Life, is committed to letting people know that they are not helpless and that they do have resources. So as we address our very ethnic population in Alameda County, we're guided by 2 executive orders. The Executive Order 12898, which was signed into law by President Clinton, is what we commonly call the Environmental Justice Executive Order. And then under George Bush, the Executive Order 13166, which provides limited English proficient populations meaningful access. And the rules and regulations that came through those executive orders guide our work in Alameda County. But the point that I'd like to make is that when we outreach to minority groups, that we have to go with some intelligence. That means not the intention to do things the way that we do, but to identify in a targeted way who those minority populations are. The U.S. Census data has very gross names for minority groups like white, black, Asian. There's so many differences linguistically and culturally that this doesn't really serve us. So as we go out to do targeted work, we must know who we need to talk to and where they are. And I do recommend the Stanford University Ethnogeriatric Curriculum because it is a great place to start to begin to understand where the background and some of the dispositions that some of the minority groups might have. Alameda County is very special because we have a pipeline to minority groups. A lot of times the groups that will be served by Alameda County's service delivery system, as Alex described, are services that are very much needed for people who are poor. And often, as you know, with limited English proficiency, some of the households in Alameda County are linguistically isolated, which means that there's no one in the household that speaks English who's over 13 years old. So we have a lot of need in the community in terms of social and health services. Alameda County, as I said, has a pipeline, and people come. So in my position as the Hospice Systems Coordinator, I work with the Behavioral Health Services Administration that does outreach and contracts to provide services for thousands of people in Alameda County. The Public Health Department sends over 600 nurses into the homes in Alameda County. The Social Services Administration, the in-home support services, has 15 to 19,000 clients in Alameda County where people are being provided service right in their home. And we see this as a brilliant opportunity to expand those services to include palliative and end-of-life care. And this is one of the ways in which we hope to increase access for those communities. The last point I'd like to make has to do with workforce development. The Healthcare Union had published a study that indicated by 2013 we would need 375,000 additional in-home and personal care aides, 581,000 nurses. We'd need an 18% increase in LPNs and LVNs, navigators, health workers, community aides. All of these individuals, some of the newer positions like navigators and assisters, people who come from other countries have often medical backgrounds. They end up sweeping floors or washing dishes because their backgrounds don't count in America. And if we can identify some of these individuals and cultivate them, employ them, then our workforce can be accessed in a way and by people who look the same as some of our patients. And this is a tremendous benefit to people who are in serious health situations.
Thank you so much, Marilyn. So Jean, do you want to tell us from your perspective?
First, I want to thank Vijay to give me this opportunity to be here and do the presentation. CACCC's mission is to build a community in which the Chinese American can face the end-of-life issue with respect, dignity, and with a meaning. That is never an easy topic for anybody, for any ethnic group. I would like to say especially for Chinese, because people you cannot talk about it. So founding CACCC is really a big challenge in trying to promote the idea that we all going to die someday. When we're born, we are going to die. As when we welcome the newborn baby with such joy and preparation, why can't we prepare death in a positive way instead of a negative way? So what CACC has been doing in the past few years that we are a coalition. So we partner with a lot of agencies, with hospitals, and we also get grants from other organizations. We have grants from Stanford, to do, also working with UCSF to do the translation of Advanced Healthcare Directive. And we do a lot of community outreach. We average about at least 10 to 15 community outreach seminars, average 30 people at each time. So piece by piece, every year we're trying to reach at least 1,000, 2,000 people here and there, trying to spread the message out. And we also do, like Sandy mentioned, we do a lot of translation for the posts so people can understand what's the difference between post and Advanced Healthcare Directive or DNR. Because when you're not sick, you don't want to deal with any of the medical terms and trying to avoid it. But unfortunately, these are something that we can really plan ahead and to make our end of life much, much easier. And we also do a lot of volunteer training. not only the volunteer, we have 3 volunteer training already, which generate about 100 volunteers that spread in Southern California, Northern California, San Francisco area, and South Bay area. We send our volunteer to the hospice agency that we work with, and for Laguna Honda Hospital, lots of volunteers go there to serve their patient over there on a regular basis. And besides the regular volunteer training, we also do professional training. We are training the medical doctors and medical MA or medical nurses, because they are different specialties. They are not palliative care doctors. They don't know how to start the conversation. And unavoidably, they will face situations like that. They need to bring that conversation up. So that's part of the training we're doing too. We have a speaker bureau who we train speaker to go out to community to talk about end-of-life issue. We also use a lot of TV and media. There are Chinese channel, radio station, and TV. Lots of the Chinese American, they only watch those TV, not a regular TV. So we use that to spread our message, encourage people to face death on a positive way. When we first started, no media want to help us, really nobody. But gradually, as the baby boomer becomes aging, it becomes a subject that no one can escape. So more and more, they are more acceptable, and every time we have event, they will help us spread the news, and then we have a great outcomes. So that's one way to do it. And one of the newspaper even produced a series of articles for us. I can't remember exactly how long it lasts. The World Journal has published it for a whole year. Every week, they will publish an article about end of life, just to plant the seeds so people can face it. We also go to a lot of senior housing to do the presentation, letting the senior knows if they can take care of their end-of-life issue, if they can fill out advanced healthcare directive, that's the best gift they can give for themselves and for their loved ones. Lots of the Chinese American also face the issue of not understanding the American medical system. I myself, I'm the chair of CACCC, but by trade, I'm a medical interpreter. I'm an agency of medical interpreters. So I have encountered many of the situations talking about course of treatment. I would like to mention a couple of them that just happened a couple weeks ago. One of them is that, I'm sorry.
Just 30 seconds.
So
tweet about each
I really want to emphasize the culture difference is not just one Chinese culture. People coming from different area of China has different culture background. And also the language barrier is a very important thing that the medical industry needs to emphasize on, because without communication, no matter how great the service you're providing, patient cannot get the benefits. So really hope that the interpreter can be well used, and I can tell you it plays a very important role with the patient experience that I have experienced. So thank you, I went over a little bit.
No worries, thank you, Dean. And I think there'll be time for questions. So you're on next.
Okay, thank you. When Vijay presented the question to us, I struggled with how to answer it, so I'm just going to kind of do my own thing here and hope that it works. I'll start out by saying that my colleagues have frequently heard me say that 95% of successful palliative care relies on communication, and that when things don't go well, it's usually the result of a breakdown in communication. It's generally not a medical issue, at least not in my experience. In pediatrics, the entire family becomes our patient. Most of our kids can't tell us what they want. Well, they can tell us what they want, but they can't make their own decisions in terms of their medical care for the most part. So it's of utmost importance that we acquire as early on as possible an understanding of an individual family's cultural practices, communication style, and traditions. And I use traditions in a very family-centered way. We strive to identify as soon as possible who the family decision makers are so that we can participate in uniquely tailored, culturally sensitive discussion in formulating a plan of care for the child and family. And oftentimes, the first few meetings don't make it clear who is actually running the show. You may think you know, but you may not know. So it's critical that the role of the members of the extended family is understood, including spiritual and cultural traditions that may or may not be shared intergenerationally, or even between the child's parents and legal caregivers when we're trying to get them on the same page. That can be difficult as well. We've learned, and this is not unique to pediatric palliative care, that if we don't achieve a deep enough knowledge of a family's understanding of their child's illness and its ramifications, that the ability of the family and clinical team to work together may be severely compromised. In addition, the emotional availability and cultural needs of a parent or family caregiver can be more accurately assessed because of our unique setting in which families actually move in and live at George Mark Children's House for days to months during their child's final decline. And many of them actually have been at George Mark over the years for either respite or transitional care. So oftentimes we're pretty familiar with the family and many extended members of the family. We maintain a diverse staff, and often the primary confidant for a parent is not a member of the clinical team. And in addition, it may even be another parent whose child is also at George Mark for end-of-life care. So we're really able to form community in that way. Intimate relationships are formed over shared meals, sitting outside by the fountain. We're on 5 acres of really beautifully landscaped property, and it actually belongs to Alameda County. And Alameda County was kind enough to give us a 50-year lease for $1 a year if we would build the structure. So families share meals, they can sit outside, and they can have late-night conversations in our common areas while the children are sleeping in their bedrooms. And VJ actually asked us to share a story, and so I chose one briefly. A preteen boy from a Middle Eastern Arabic country was admitted to George Mark for end-of-life care following a several-month hospitalization at one of the local hospitals. His mother and siblings were unable to come to the United States, leaving his father, and I've called him Faisal, that is not his real name, separated from his family. And we had been informed that his father had a substance abuse problem and was noted to be intoxicated on numerous occasions when returning to his son's hospital room following prolonged absences. Accompanied by a family friend who was living in the Bay Area, Faisal first visited George Mark to see if he wanted his son transferred from the hospital for end-of-life care at George Mark. Clearly inebriated, during our initial conversation, he fell asleep and actually became incontinent. After he had left to return to the hospital, several members of our clinical team expressed their apprehension at providing safe care for this family and the potential impact on other families staying at George Mark. After some discussion, it was decided that we would admit the child, having obtained assurances from Faisal's friend that he would be available to provide necessary support and resources if requested. Not unexpectedly, for us anyway, Faisal formed a close, trusting relationship with one of our male staff members. And actually, this was our security guard who was there at night. And as all of us know, people's barriers are down at night, the anxiety is higher, and our staff member actually formed a very close, trusting relationship with this gentleman. And during the 10 days that his son spent at George Mark, with Faisal present nearly constantly, he rarely left, as he had done at the hospital. There was never an issue with disruptive behavior or safety. And following his son's death, Faisal remained in contact with our staff member for several weeks prior to returning to his home country. So I think that the uniqueness of our setting actually allows us to overcome some of these difficult situations in approaching end-of-life care for children.
Thank you so much, Barbara. So as you heard their various stories, I hope that now you're filled with hope and optimism that yes, we can do this. And so with that, I'll open up to questions. Yes.
Thank you. I'm Carla Holloway from Duke University. Just let me say I'm a cultural studies and legal scholar and appreciate very much the committed and engaged stories and examples you've given. I also want to say I think it's particularly important the way in which we think about diversity. One of your handouts called The Voice of the People said, what do ethnic persons have to say about barriers? What happened to the white people? In other words, why is it that the racial, ethnic, skin tone diversity is more important than the systematic discrimination that has made the effects of diversity, these kinds of diversity, important? As long as we continue to focus on the ways in which, other than the language translation issue, but on the way in which these persons look, we ignore the fact that racial disparities exist because systems perpetuate them, not because of who these people are individually. And so if our solutions are focused on the people, and many of you, and I really appreciated the ways in which I kept hearing there are differences in the Asian American community, there are differences here. But if we don't pay attention to systematic diversity, which is one of the ways I want to encourage our conversations, even on this committee, to go, we are going to continue to look towards persons' differences as being coherent enough to address policy issue towards, when it's actually the policy makers and the ways in which we, those who are in power, create coherence when actually we're dealing with people, not with ethnic groups or racial groups. So I want to thank you for the ways in which you've helped us understand that distinction, even in the very beginning, the very first image where the physician is actually talking over the family members. When the man says, this is what I would want to do, the physician says, we're going to keep on fighting. Well, he's just told him that the disease is terminal. So there are two different messages here, and yet the attention about an African American family who wants to keep on fighting is disrupted by a physician who doesn't quite know how to stick to the message, this illness is terminal. So in that issue, I thought it was a physician that needed some training there, and not our focus on what a particular group might believe. My skin color will tell you nothing about what I believe in terms of end-of-life care. But systematic discrimination tells us a whole bunch.
So first of all, let me apologize if any of this was sensitive content. And the video was not meant to be a gold standard as much as an example to stimulate the conversation. So when I took on this panel, I knew immediately that race is a flammable issue. But having said that, I'm never one to shy away from taking on the most flammable issues, and I'm not here to even say that we have the best take on it. I am delighted that we are able to talk about it, that we have engaged. It's part of our archives now, and so we can think about it. In terms of ethnic groups, I actually think of, and I have a Caucasian friend who pointed this out, who said, we are an ethnic group, we are white. We are an ethnic group too, and how come you don't have a module on us? And I said, do you want to write it? So, no, not a problem at all. And so in that sense, when you've taken care of one person, you've taken care of one person. Each family has its own culture. And I have another separate talk, which is the social determinants of health. APHA last year did a big campaign on your zip code determines your lifespan. So if you live in Oakland, and if you want to live longer, the simplistic solution is move to Marin County, if you can afford it. So social determinants of health are ultimately the real culprit. So this topic, by being vocal about it, we are taking one small baby step towards a very long journey. Yeah, but thank you for your comments. Well said.
Thank you, Carla, as well. And I think we all recognize that conversations about end of life are uniquely challenging in their own rights. And when you couple that with conversations about end of life, with conversations with individuals who come from culturally diverse areas, it becomes even more complicated and important, and that's why we're here, to really learn and have that dialogue. I want to thank Vijay for bringing together this panel, and I want to thank each of the panelists for their extraordinarily insightful comments. It's really been very, very important for the work of our committee, and I'm sure for everyone who's here with us today. Now, I have the unfortunate responsibility of keeping our committee on task, and we'll be back here at 12:45 for the next presentation, but that means for the next 40 minutes we're going to disappear from here and walk over to another building. So I want to, before doing that, in our ways of being an educational institution, thank you with another diploma for each of our organizations. Thank you. This is for sharing.